Dr. Anoop Gupta is ready to show his slides. His title is.
So we all know, the CRT has produced significant clinical benefit over a period of time with the left ventricle remodeling. The issue is always remain 1/3 of patients, they still do not show good response despite selecting a left bundle branch block with more than 150 millisecond QRS duration. Despite that, they don't respond. And we know that the non-response CRT patient has multifactorial causes. So we don't know what exactly the cause is. So what is the current recommendation? So if you're talking about class 1A indication, that is left bundle branch block with more than 150 millisecond QRS duration in normal sinusitis, a patient on optimal medical therapy, that is class 1A indication. The other one, the class 1B indication, it is between 130 to 150 millisecond. And particularly the female gender, they say they respond much better than the male gender when the QRS duration between 130 and 150. But again, it's a class 1 indication, but the level of category is B. The others are non-LBB criteria. It's a IVCD or a right bundle. It's a class 2 indication. And most of the time, if the QRS duration is less than 130, we in fact don't consider putting a CRT. It is going to become more harmful to those patients. Upgradation, yes, it's depend upon class 2A to 2B. Whether you really want to upgrade from a dual chamber pacemaker or if you're doing a AV junction ablation, whether you want to put a BiV or not. So that is class 2 and class 2B indication. So what exactly right now? Class 1A, no question, left bundle more than 150 and class 1B between 130 and 150. And the female gender, they do better in this class than the male gender. This is a controversial subject. Again, patient with the left bundle branch block, dilated cardiomyopathy, many times we see these patients has got atrial fibrillation, and we know that, these patients, they do not do well despite putting a CRT and AV node junction ablation also. So right now, what is the class of indication is class 2A. And if the patient, you are doing again AV junction, so again, it's a class 2A indication. So, it is not class 1 indication right now, but, selected patient, you can think about doing this thing, AV junction ablation, putting a CRT, or probably doing a physiological pacing. So what are the definition of CRT response? So the most important thing is the clinical measurement assessment, NYHA class improvement from 3 and 4 down to 1 and 2. Most important thing is the quality of life of the patient. You can perform a 6-minute walk test, see the exercise duration after implanting CRT, how good they have done. Echo has got definitely a role. And what Shanmuga was saying in physiological pacing, sometimes, even with the BiV pacing, acute hemodynamic parameters are pretty good inside the cath lab. Even the echoes are pretty good. Chronic, you have to look into the ejection fraction. What are the reduction in end-systolic and end-diastolic volume, and how much is the regression of the mitral regurgitation? That's very, very important. And the other measurement assessment is the most important thing is the burden of the heart failure hospitalization. If you reduce the heart failure hospitalization, that's very good. And morbidity and all-cause mortality. So these are the other measurements which you see. How do you define non-responders? So one thing is that, if the patient is getting worse after receiving the CRT implantation, after 6 months of CRT implantation, if they are not improving the functional class or they have increased their ventricular remodeling, that's again categorized as the non-responders. Patient has initially responded to CRT, but now started worsening symptoms. These are the subset of patients that don't do well on over a period of time. And what is the main reason for non-responders? This is very, very important. Improper patient selection. Again, if it is a suboptimal lead placement or inappropriate device programming. So nowadays, with the good device programming and good hardware, these two factors are very, very less. So the most important thing again remains you have to select your patient properly. So proper patient selection, that's very, very important. So these are the category of the patient. We all know, if a patient has a non-ischemic dilated cardiomyopathy, they are the best. Female gender, again, best. More than 150 millisecond left bundle branch block. What is the end diastolic volume? If it is below 240 ml, that's very good. If the heart is pretty big, the end diastolic volume more than 240, they are not good responders. You have to have a discontinuity either on EKG or on an echo. If you get a cardiac MR or a CT, and if you see it's a very high grade of scarring in the myocardial, they are not a good subset of patients. So no scarring, they are very good. RV function, again, is very important. If RV dysfunction present, they are non-responders most of the time. Lead position, again, you have to be on the base and on the lateral pass. So posterolateral basal anatomy is the best. Maximum BIB pacing, almost 100%. If it is less than 99, 98%, patient has got a lot of PVC burden or atrial fibrillation, intermittent, paroxysmal. They do not well. They do not do well with the CRTs. And the AV and the VV automation should be very good after putting the device. So if you see what are the main reason, again, suboptimal AV timing, arrhythmias, and anemia, these are the things. And if the patient is having less than 90% of BIB pacing, then obviously you have to think about it. So try to correct these factors. If you can correct these factors, probably you can make more non-responders to responders. And again, with the lead thing, one thing I want to emphasize now, multi-point pacing, if you are doing multi-point pacing, sometimes you can improve the LV function by doing multi-point pacing also. So that again is a factor. So what it goes like, the graph shows the wider the QRS, more the benefit with the left bundle branch block. Non-ischemic is much better. Female gender is much better. If it is a male, they are not doing too well. And narrow QRS, they don't do well. If it is a non-left bundle branch block, they do absolutely not well. So again, the class 1 indication remains the left bundle branch block with more than 150 or between 130 and 150 millisecond. Rest everything comes in class 2A and class 2B. So this is very important. Sometimes you have seen, you have selected a good patient with a left bundle branch block, more than 150, 160, they do not do well. So sometimes the baseline QRS duration does not predict clinical response of CRT. And that is the reason 1/3 they do not respond well. And the other thing, many times the QRS narrowing after CRT does not correlate with the hemodynamic clinical improvement. Many times after putting the device and the QRS become absolutely normal, and the patient doesn't improve and patient LV ejection fraction doesn't improve. So we start wondering that what is wrong, because the ECG has become absolutely normal, why the patient has not improved. So this is again very important. So the QRS is not the only. Sometimes, we see discontinuity with not a very wide QRS also. And that is one of the reasons, almost 1/3 of the patient with the more than QRS duration of 120 milliseconds, they do not exhibit any discontinuity. And that is the reason of non-responder to CRTs. And in fact, 1/3 of the patient with narrow QRS, they show ventricular discontinuity and they may be a candidate for CRT. So, you have to look into these patients also, which patient you can really put a device and you can improve. And particularly, means the narrow QRS ischemic male patient, sometimes they have got a discontinuity and they can do well in putting the CRT in addition to ICD, which are indicated in less than 30% of patients. And failure of QRS narrowing is a poor predictor of response to CRT, all we know. So many factors came and multiple parameters of the echo came, but not a single parameter of the echo can show that these are the marker which can definitely improve response to the patient or not. So still, we are still depending on the QRS, on the EKGs to select our patient. Some of the echo parameters we do take into consideration when the ECG is borderline between 130 and 150 millisecond with left bundle match morphology. So what the narrow QRS duration randomized trial? So only the narrow CRT, which was between the CRTD and a dual chamber ICD, male patient ischemic class 2-3. This is the only study which showed some benefit of CRT. Rest all things, rethink, echo CRT, lesser, they were all a negative study. They never improved with pacing on and off. So, narrow QRS again is a debatable thing, and right now it's not indicated for CRTs. So what are the parameters of discontinuity? How you can make out? Again, I would say the ECG is the king. The QRS with left bundle branch block more than 150. Select those. There are multiple echo parameters, and now a lot of tissue Doppler and strain imaging that can help. Particularly, the radial strain and what Shanmuga was saying, right bundle branch block. If the QRS duration more than 160 millisecond, the radial strain can definitely help you, whether it is more than RBB having some unmasking of left bundle branch block or not. MRI and CT, they definitely has got a lot of role now selecting the patient, particularly the ischemic heart disease, whether there's a scarring or not, how good or how bad the venous anatomy, where you're going to place the lead, does it correlate with the discontinuity or not? And some of the spec perfusion imaging can also guide you about the discontinuity. So this is either a CT or a cardiac MR. So what you can come to know with the multidetector CT scan, the coronary venous anatomy, the localization of scarring, where you exactly want to put the lead. Do you have any alternative where the delayed conduction is there? You can put there. How much is the mechanical discontinuity? And you can have integrated information regarding the relation of venous branch of the segment of the discontinuity with the scarring. So you will be very, very wise before putting the lead. Again, during the implant, impact of the LV pacing side, that's very, very important where exactly you're using. So again, it should be on the basal and the posterior part. So if there's a delayed in the site, so if you see this, so yes, the parameters definitely improves. So pacing at the most delayed part, the end systolic volume that reduces, the ejection fraction increases, and the walk distance also improves. So most important thing, again, you're selecting the vein where exactly you want to put the lead and see where the delayed part is. QLV on table is very, very important. You see where exactly the QLV. So what it says right now, the algorithm says more than 150 millisecond LBBB, no question. You select the patient, put the lead, try to maximize the CRT response by programming the device properly, selecting the lead and everything. If it is a non-LBBB, RBBB or ICBD, again, look into whether there's any delay or not, what are the radial strength, and if that is the thing, you can think about it. These are called controversial, like, less than 130. Again, these are controversial, whether you really want to put or not. So coming to RBBB, what Haigreve raised in the previous also. So it has to be more than just RBBB. So if you have a RBBB with radial discontinuity, then in these subset of patient, you can offer CRT in certain subset of patient. So again, if you see the electroanatomical thing, so that again, comparison the left bundle branch block more than RBBB with the radial strength, these patients can be offered and can see, because probably this patient has got some kind of underlying left bundle branch in addition to right bundle branch block. So if you have a significant radial discontinuity, the ejection fraction improves. So the septum with the posterior wall, if you see there's a delay of 293 milliseconds, definitely improves. If there's no delay and there's no radial discontinuity, these patient doesn't do well, and this patient died after 2 months of CRT, no improvement in this. So important thing is again to look into radial discontinuity. So on table, when you're taking a non-left bundle branch block with a QRS duration of more than 160 milliseconds, what is more important is the QLV. You see the QLV, how much is that? If it is less than 100, they are not a good subset of patient. If the QLV is more than 130, 140 milliseconds, these are the good subset of patient who probably are going to respond with the non-LBB subset also. So one case, again, this was a 60-year-old lady, refractory heart failure. There was a late gadolinium enhancement on cardiac MRI, LB ejection fraction 15%. So obviously candidate for dual chamber ICD. So we thought, since this lady had an underlying right bundle branch block with some radial strain and left bundle, so we decided to put his bundle CRT, and you can see the ECG after implantation was pretty good. And on table also, with the his bundle pacing, the QRS narrowing was remarkably low. It was less than 90 milliseconds. And this was the fluoroscopic picture. So, again, his bundle pacing with the conventional ICD at the RVA apex. So these kind of subset of patients, they do well. And this lady, now it is almost more than a year. Her LV function has gone up to 50% and she's asymptomatic. So this kind of patient you can select. Sometime more than that, again, this was a patient in which the QLV on table was 160. So we thought this was a right bundle, left axis with the trifascicular block. The indication of device, what patient had a multiple episode of syncope with post CABG. So obviously patient was a candidate for dual chamber EICD. We thought about putting a CRT-D, but after putting the LV lead also, the QRS was not getting narrowed. So we decided to put the additional left bundle lead. So we did a lot CRT-D with the left bundle. The QRS became very narrow, and this patient also improved remarkably. So there are certain subset of patient in which non-LBB patient you can select who are candidate for ICD implantation. You can go ahead with CRT-D. And if the QLV is good, you can do conventional CRT. Otherwise, you can do a physiological pacing. And physiological pacing, they do pretty good. So if there's if right bundle branch block, mechanical or electrical delay, there's no delay. So conventional CRT is never going to work. You can think about doing a physiological pacing. If there's a mechanical or electrical delay, yes, CRT is going to be useful, but make sure on table, you should be ready to put additional left bundle or his bundle lead if your conventional LV lead doesn't really work. So right now, what is the indication for target population? NYJ class 3-4, LV ejection fraction less than 35%, white QRS LBBV, dilated left ventricle sinusitism, class 1A indication. NYJ class 3, ejection fraction less than 35, right bundle or IVCD, dilated LV, its indication is class 2A indication. If it is white QRS more than 130 millisecond with indication of ICD, again, the medical and the medics, they said that, it's better to put a CRT-D rather than the ICD. So that they again become a candidate for CRT-D implantation. Chronic AF, if they are going for AV node junction ablation, either physiological patient or you do a BIV pacing. Narrow QRS, this is again remains a debatable subject, but in some of the narrow QRS, if the patient is going for an ICD implantation because of the ejection fraction less ischemic heart disease, and you think that there is a mechanical discontinuity, you can offer those patients a CRT. And any brady pacing, any AV block with LV ejection fraction less than 40%, the patient is going to require RV pacing more than 90% of the time. You should give a CRT, which with the LV dysfunction. So to conclude my talk, CRT has become an important part of heart failure patient. Updated guidelines broaden the scope of patient who can benefit it. So non-LBB patients, some of the patient can be benefited. Current guidelines, QRS duration, not the morphology. Symptomatic heart failure, low ejection fraction. Certain recent studies, they have cast doubt whether the echo-guided selection can be a better prediction for CRT or not. We don't know right now which are the parameters of echo. They are really going to be good. Increasing data coming with the atrial fibrillation and patient depending on the RV pacing, whether we should give them CRT upfront or not. Programming, again, definitely remains the most important thing to improve the outcomes. And the current devices has got multiple diagnostic information, that can, in fact, you help in better management in medical management also and improve outcomes. I'll stop here and I'll take your question. Thank you very much.